Are we going to record this?
We are recording now.
All right. So, in that case, tonight's lesson plan is to kind of walk through the PowerPoints that are already uploaded in the module. Um, in particular, we're going to start with one that Josh Hart created last year, and several of the students have sat with Josh, so they know him. And I'm not going to read all of the pieces of the slide, but talk through the important points of it because Mr. Hart added some things down along the bottom to help guide you. So when you look through it, you'll see that all the notes are there. So next slide, please. So tonight we're going to talk about what keeps people from being hospitalized, to kind of begin to think about your community resources, which this is a great time to begin making some kind of a list for yourself about who you can refer to, particularly if you're going to remain in the community in which you're working. We're going to talk briefly about involuntary versus voluntary commitment, and we're going to talk about follow-up and procedures that can prevent rehospitalization. Because our goal is basically to keep people out of the hospital as much as possible and utilize various levels of care depending upon the needs of the patient. So next slide, please. So this was, oops, if you back up one more, I'm sorry. This was put together with the concept of looking at the VA as the model. And so for those of you who are not familiar, community-based outreach clinics are called CBOCs, and they have different procedures than if they were in a VA proper hospital. So with someone who's in the CBOC, they can admit the person that they have, should they decide that they need admitting, to either a non-VA hospital or a VA hospital, in which the cost of coverage would be covered, and this is a procedure for doing it, but unless you're working in a CBOC, it is not as important as understanding that getting people admitted to a hospital is a process, and it is very site specific. Next slide, please. So the process as it relates to real world is there are a couple of reasons that people get admitted to the hospital, but the primary umbrella in which you can consider the requirement for hospitalization involves one word, and this is it: safety. People are admitted for safety reasons, either safety for themselves because they're a danger to themselves because of their behavior, either their behavior is such that they are unable to care for themselves, such as when people develop a delirium, or their behavior becomes so agitated that other people are at risk because of their misinterpretation of the world. So for those particular reasons, people may be hospitalized. Suicide risk is an important piece of this process, and rather than go into great detail here, we'll continue to talk about it as we go. Having communication with the team is very important because you, as the nurse practitioner, are not required to do all of the pieces. This is where you utilize the people that you're working with to assist you to help with this process. So should a person be hospitalized, it's helpful to tell the person before you send them what they can expect so that they can anticipate the delays that may come up, particularly if they get sent to an emergency room. And to clarify what the plan is, that if an individual was having a lot of delusions or was grossly psychotic or suicidal, that the plan was stabilization in the hospital with discharge home as soon as possible, if at all possible. Next slide, please. So in the process, many times getting a person hospitalized is a negotiation process, one of which one has to be pretty good at making a sale to define what the risk-benefit ratio is to hospitalization, because most folks are going to be reluctant to go to the hospital, particularly if they'd been admitted before. So explaining to the patient the risk-benefit ratio, which would be, I'm really concerned about your safety. I feel that at this time, because your judgment is clouded by the degree of depression that you experience, and this is not unusual, that your brain is telling you that you should be dead and you feel that way. But because I value you, I feel like we need to protect you from yourself, which means that we need to admit you. So some of it's about explaining to the patient the necessity for hospitalization, uh, clinical limitations. Again, it really depends on where you are and how close you are to whoever is available for admissions. Because, as I said, it was site specific. The hospital at UAB would admit through the emergency room. If it was another hospital, they might be able to admit straight onto the ward, depending upon whether or not the nurse practitioner had a collaborating practice with a physician with whom, as part of the team, they could help get the patient admitted. So this process is dependent on your location. Hopefully, each one of you may have seen a patient who was identified as needing hospitalization and seeing the process. So how many people on the call tonight have been involved in getting a patient admitted to the hospital? So just say you have, if you have or not. Okay. Okay. Karen, do you have a mic?
Yes,
Could you just say, okay, could you just say what your experience was in helping to get that patient admitted in about 3 sentences?
um, like you said, it's a collaborative um, effort. In 3 sentences, we had to do a handoff. So, as a registered nurse, I had to call and do a nurse-to-nurse report on the patient. The physician had to call and do a doctor-to-doctor, kind of like report. And based on if there's rooms available. But most of the time where I worked at, they were really good at the VA to getting them into the emergency room right away.
All right. Well, thank you very much.
No
Karen
problem.
said one of the major pieces that usually slows down the process is bed availability. For
Mm.
folks who work at UAB, I think you're probably acutely aware that there are times in which there's no bed availability, and many times people end up identified as needing to be hospitalized, but having come into the emergency room without a place to admit them to, they're held in the emergency room, which emergency rooms are not a safe place for psychiatric patients who are suicidal. So usually what that would incur would be additional cost to have a sitter sit with the person just to maintain their safety. So next slide, please. So knowing community resources, and I'm really not sure what this is besides some community resources that would be available to you, including United Way. And next slide, please. Involuntary commitment, because involuntary commitment, again, varies from place to place. In Jefferson County, the involuntary commitment has to be done within the court, and there is a procedure in which the family member or someone from the healthcare team has to go to the judge to request this commitment. But one of the things that I do know is that every state is different in terms of the process. But in Jefferson County in particular, if you looked at the law, there was a piece in it that stated that the family could write a letter to the judge, which was kind of an interesting idea, that if you're going for an involuntary commitment, usually there's some degree of urgency to it, and writing a letter seems to indicate that maybe as far as the law is concerned, there may not be. So next slide, please. So in terms of the history of involuntary commitment, there is a case here about legal safeguards for individual protection and rights, and this was Lynch versus Baxley, which was, if I remember correctly, a case in which this person was involuntarily admitted to the state hospital for a prolonged period of time. So history of involuntary commitment in the 1990s was expanded to include the threat of an overt act that is probable based on previous history. Again, part of the problem with getting a court order to involuntarily commit someone is that it requires that the individual be on the verge of doing something or may have already done something, which is kind of a bit like getting a restraining order for someone who may not pay attention to it. There is a lot of risk involved in it to the people who are looking to get the involuntary commitment. Next slide, please.
Oops. Uh-oh. Hold that thought. Hang on, everybody.
Okay, so while you're working on that particular piece, usually what can happen is that there is a possibility that somebody can be admitted for an involuntary commitment on a 72-hour hold, which allows the process to take place because of the need to maintain the safety of the individual. So commitment criteria is that they have to demonstrate that they're seriously mentally ill. Like if I was upset with someone, I couldn't get them committed because I was mad at them, but there had to be a demonstration of the presence of a threat of substantial harm to themselves or others, and that the individual was unable to make rational and informed treatment decisions. And without treatment, that they would get worse. The treatment is the least restrictive alternative available, which this is a sentence that's really important because this least restrictive alternative concept takes place across the continuum of care, so that it is conceivable that a person can be court-ordered into treatment in a least restrictive alternative, which would include outpatient. So next slide, please.
Would you like to do a poll?
A poll sounds like a really great idea.
A poll! Let's do it.
Yeah, this is where we need the drum roll, right?
Absolutely.
So what does the term least restrictive treatment environment mean?
What does that mean?
And go to your clickers and choose the option that seems the best to you. And this is where we do the 30-second thing, or maybe 15 seconds. To your clickers, people.
Yeah. So once we get a pretty high percentage of voting, well, that looks great. Pretty much.
Okay. All right. So the overall majority.
The consensus?
How did they? The consensus?
Yep, 100% of those who voted said it's
of those who voted. Okay. So they got this answer correct.
Mm-hmm.
So the least restrictive is essentially involved with safety. And if you keep that particular piece in mind, it can be very helpful. Next slide, please.
Mm-hmm.
So this covers who can file a petition to initiate involuntary commitment procedures. And any person can file a petition with the probate court in accordance with this particular section of Alabama Code. Again, this does not apply to other states. So anyone who is in Florida, Georgia, Louisiana, Tennessee, Arkansas, Oklahoma, or Kansas, this is not going to apply to you. So it's important that you take a look at what your state law is, knowing that this is not going to apply to you. Next slide, please.
And that's kind of a confusing thing. I think that some of what we do is, national, federal regulations, but then things like this are entirely state specific. So
County specific, actually. In this
sure.
particular case, it's county specific. So the mechanism of how one is involuntarily committed from the 60 some odd counties in Alabama may change, particularly in rural communities. They don't necessarily have any treatment facility. And then they have to add an additional piece of negotiating to a county outside of their jurisdiction, accept the patient outside of their jurisdiction, which when I was in Baldwin County, that was before they had a treatment facility there, and the police had to negotiate with the police in Mobile County to make the transfer of the patient so that they can take him to the hospital in Mobile. So this involuntary commitment process ends up also involving the police in Alabama, which for many people it ends up a sticky wicket, particularly when you're dealing with paranoid people who think that the police are after them anyway.
Mm-hmm.
So involuntary commitment process, there are prescriber limitations in which part of the involuntary commitment is to commit the person to a space, an environment, but it doesn't necessarily give you permission to do anything to that person if they choose not to have it happen. So the person's committed to the space, but if they still retain the right to refuse medication. So if they are very out of control and require medication, that would require an additional court order in order to medicate them. Has anybody had that experience in which they've had to experience the provider having to go to court to medicate a patient against their will? Sabrina, would you care to just, in 3 sentences, just say a little bit about what that experience was like?
On my last job, I was on the forensic unit at the state hospital, and pretty much all of the patients that I had are court committed because most of them, as a rule, would refuse medication if given the choice. So unfortunately, they're all court committed and that's something that's brought up is that if they don't take their meds, that we can give it to them in an IM if necessary.
Okay, so that was part of their being committed to the forensic unit, that they would be provided medications against their will?
Correct.
Okay. It ends up getting to be quite tricky depending upon what state you're in about how that procedure takes place. But given another option to choose, to your clickers again, how would you handle a floridly psychotic patient who is refusing medication on an inpatient unit? You have several options. One is to document the refusal, but to continue to offer medications, wait for physical aggression, then administer IM Haldol, develop a report to discover why they are refusing, and if the patient is a danger to self, administer medication. So which would you choose? Now, this is based on the fact that you don't have a court order to medicate this patient against their will. Ten seconds. 5 seconds. Simone, and the answer is?
What is the best answer? Is there a best answer?
Flip back to it again, would you please? And we'll talk through it.
Oh, can y'all not see it? Let me see if I can share it again. Can y'all see it now?
We can see how people chose.
Oh, that's fun.
In this particular case, the best right answer, because you don't have a court order to do this, in the sense is that, which would you do? You document the refusal, but continue to offer medication because they can be floridly psychotic, and there are other ways that you can work to treat them. So that would probably be choice number one. To wait for them to be physical aggression and then administer IM Haldol is kind of almost malpractice, because you're not making any attempt to manage the patient within the environment, and just waiting until they get physically aggressive and then shoot them up with Haldol is just kind of cruel. Develop a report to discover why they are refusing. The only reason why that's less correct than the first answer is that individuals who have severe mental illness often have, and it's part of the disease process, that they lack insight into their disease process. So to try to discover why they are refusing, usually the answer is going to be, I don't need medication. There's nothing wrong with me. You all think I'm crazy, but there's nothing wrong with me. So that's probably how, if you ask what they're going to say about why they're refusing. And if the patient is a danger to self, administer the medication. Again, this is probably going to have to require quite a lot of documentation for why you're going to administer this medication. And it is definitely going to be looked at, particularly if the patient decides he wants to sue you for assault and battery. So continuing to document the refusal, but continue to offer in an attempt to kind of develop a rapport with the patient is probably your safest bet at this point with a floridly psychotic patient on your unit. Taking care to be aware of stimulation and manage the environment as well as you can, which I would imagine that at the same time during treatment team there'd be a discussion about the patient and how they were progressing and what action needed to take place. Some folks have had the experience of people who are floridly psychotic on a unit being managed for a while until the patient reached a point where either they accepted the medication because they wanted to get out of there, or that they got a court order in order to medicate the patient against their will. So a lot of times that's what I've seen happen. So that's kind of walking through those particular options. Next question, please, or if we can go ahead and move on. Because this is so state specific, let's go ahead and move through this. Alternatives to involuntary commitment include outpatient treatment, group therapy, individual therapy, or medication. So it is conceivable that people can be court-ordered into various therapies depending upon what's available. Inpatient treatment with weekends home, respite in a transitional home, group homes. Nursing homes have, in essence, become kind of de facto psychiatric hospitals, where many schizophrenic patients have ended up in nursing homes. Unfortunately, nursing homes are poorly equipped to handle them, or state homes, which currently I would imagine that most states in the United States are poorly equipped to handle these folks because there just aren't enough beds for them. Next slide, please. So again, these are very Alabama specific, which translates to we're not testing you on this particular information, but know that there are durations to any of these commitments. It's not for the rest of the individual's life, and reassessment has to take place as time goes on. So understanding and facilitating voluntary hospitalization is about you as a provider assisting the individual to understand how hospitalization can be beneficial. Hospitalization is for safety and to safely allow the individual to become stabilized, oftentimes rapidly treating the patient with medications much more rapidly than you can do on an outpatient basis. They are monitored for suicide risk factors, and in terms of active and suicidal passivity or passive suicidality, to get hospitalized, the person generally is assessed in the emergency room, and they very seldom, in my experience, admit people who are passively suicidal because they just don't have the space for people. You're going to develop some kind of a plan, including discharge planning and goal setting, with pharmacological interventions to help the individual. Planning also for non-pharmacological interventions. Most hospitalizations are very short and brief, often almost more of an assessment and stabilization process than anything else, with the additional treatment taking place outside of the hospital. Next slide, please. This is really helpful information, but not necessarily to anyone who's not in Alabama. Next slide, please.
We can have a couple of polls after this slide too.
Right. So intensive programs, one program that is particular for individuals with serious mental illness is this assertive community treatment team, which is a program in which taking into consideration that those with serious mental illness generally have a great deal of problems with a number of issues, one of which is time management, getting places on time. Often they require other people to transport them because of their serious mental illness. They often are on disability and don't work, and therefore are at the mercy of other people to get them to their appointments. Often when a person is barely hanging on and may not know what day of the week it is, to anticipate that they're going to keep an appointment is sometimes.
How about we do a poll?
Poll. All right. So, assertive community teams provide what type of service to patients with serious mental illness? First answer is a place for people with serious mental illness to socialize, a treatment in the least restrictive environment, and a clinic for after-hours appointments. So, to your clickers. I'll get another 5 seconds for anybody who's slow on the draw. Okay, what's the response rate on this one, Simone? 100% of the people got the treatment is the least restrictive environment. Very nice. All righty.
All right.
So let's go ahead and go on to the next one then.
We actually have a thematically consistent poll question.
Okay.
Right here.
All right. So what role would a psychiatric mental health nurse practitioner have on an ACT team? The first choice is he or she would take the lead in directing patient care. There is no role for a psych mental health nurse on an ACT team. He or she would provide care specific to psychopharmacology. So choose the best right answer in this particular case. We'll do another 5 seconds. Okay.
Are y'all able to change a selection after you make it? I've never done one of these, so I just don't know. Or does it kind of lock you in?
I think you can change it.
Okay. I just didn't know. Oh, it doesn't let you change it?
Okay, thank you, Karen.
That's rough. Huh.
So on this particular one, he or she may take the lead in directing patient care, and it really depends on where the individual's at. Most of the ACT teams I've seen are usually led by a psychiatrist, but there can be some that are led by the psychiatric nurse practitioner. Has anybody here had any experience with ACT teams in terms of who the leader on the ACT team was? Okay, we've got crickets. In Oklahoma, psychiatrist, not yet. There's one answer here that rolled up. Case manager-led team. Usually it's the individual who has, who's been designated as the leader for that particular thing. It may be a lead social worker. It just depends. But generally, the nurse practitioner, there's no reason why they couldn't take the lead in taking direct patient care. And so there is a role for a psychiatric mental health nurse practitioner on an ACT team. And in particular, it would be to provide care specific to psychopharmacology. So their focus would be taking their expertise, which involves taking into consideration the underlying physiological issues that the person has. So this is where knowing how their COPD and their diabetes enter into the decision-making process of how you're going to treat the other pieces, which include what psychopharmacology you're going to use. So in that particular case, there were several correct answers on that one, and to kind of bring out the rest of the pieces with what the role of psychiatric nurse practitioners are. So assertive community teams are something to consider. They are perhaps something that you might consider after you've been out of school for a year or two and having had some experience in a stable environment.
Like you had said, Dr. Fogger, there's no reason why a psychiatric nurse practitioner couldn't be the person, doing the assessments and making the diagnosis and managing the whole medication-related treatment plan and referring to other services as appropriate. Part of what's getting complicated, I think, for nurse practitioners these days is as there's the movement toward more independent practice, it's kind of the way business has been done for so long in so many states that it was sort of defaulted to the MD or the DO. It was kind of defaulted. Oops, I need to plug in my computer. It would default to the psychiatrist, that they would be the one leading it. But it's each state's practice act. Your practice act in Maryland or Oklahoma or XYZ state's going to say what nurse practitioners can do. Now the question then becomes, what is insurance going to pay for nurse practitioners to do? And that tends to be driven by whatever Centers for Medicare and Medicaid say. That CMS, they'll say, sure, nurse practitioners can do anything that doctors can do. And there have been changes in the last 5 years expanding what Medicare and Medicaid will reimburse nurse practitioners to do at an 85% level of what they'll pay physicians. So part of why a lot of things in hospitals and clinics and community agencies, part of why that's been defaulted to physicians for so long is because they'll get paid more for those services if provided by a physician. But that doesn't necessarily, Medicare doesn't say what nurse practitioners can and can't do. They just say what they'll pay for. So part of what you'll see nurse practitioners and nurse anesthetists and CNSs doing, it should fall within your state's scope of practice, what legally you're covered to do. But it may also be restricted then, well, is anybody going to pay for it? Or are they going to pay as much? So, but who knows what this is going to look like in 5 years, 10 years. But that's all I wanted to say about that. Just some things to think about. Why don't nurse practitioners do this? Well, because they won't get reimbursed as much for the service. And it's in the best interest of the hospital to have MDs and DOs billing for things because they get more money. But all within the context of your practice act, of course. That's really what we ought to be doing within that scope.
This particular piece refers to the MICM admission criteria. In general, their criteria is that an individual has serious mental illness, usually, which means that the individual has had serious mental illness for some time. They probably have a diagnosis of schizophrenia, schizoaffective disorder, bipolar disorder of a serious nature and for a prolonged period of time. They would need to have severe functional impairment so that it was a problem for them to get out and about and to keep track of things. Often the lack of awareness of their own mental illness is part of the process. And they may be inadequately served. Translation, that having outpatient care scheduled for them is not effective because they fail to show up, because they can't keep track of when their appointments are, or that because they have a great deal of problem getting someone to bring them to the clinic that's not a reliable source, that they can't make their clinic appointments even if they tried. So they usually have high hospital use, and the MICM is designed to essentially cut down on high hospitalization and to limit access to hospitalization by ensuring that the individual stays healthier outside. So next slide, please. So in summarization, were you going to say something?
Nope. I was just saying summary. Summary slide.
Thank you. So in summary, negotiation is important to exploring barriers and encouraging voluntary commitment. So the bottom line is if you can talk a person into going into the hospital, it is an easier process with a lot less complication to it, and to have the individual willing to go to the hospital is your first thing. Mental health providers do not have the authority to commit a patient to the hospital because it has to be done by court order. And one follow-up option is with a serious mentally ill patient that they can be included in assertive outreach programs to ensure intensive outpatient approach, which basically hopefully keeps the patient out of the hospital. Community resources are available, and your team should consist of a therapist that can explore the client's needs. So I guess in particular what I want to make emphasize here is that as you are finishing your final semester, as I started to say earlier in this series, that having a list of places that you can refer to is going to be really gold to you when you start practicing, because when you're struggling with what to do with a patient, the last thing that you want to do is wonder who you're going to refer them to, where you're going to refer them to, and what phone numbers you need to be calling should you need to call. So if you've got that all set up for yourself, it'll make it a whole lot easier. It's going to happen. Have it someplace where you can find it, so that you can just flip it open or go to that document to review the resources that you've already set up for yourself. It is part of going into practice to have yourself the resources. Sometimes you have somebody available to help you find those things. Other times, maybe not, but anticipate that worst case scenario, it's not going to be available to you and that you want to do well. So is there another slide, Simone?
I don't know. Nope. Reverse.
Yeah.
We have
Okay.
a couple other opportunities for discussion, though, if you want to do these other polls we have.
Certainly.
Okay.
All right. This particular one is one that is related to the readings out of Kaplan and Sadek, because eating disorders are a peculiar lot in the sense that we had minimal readings set up on eating disorders because it is an area of extreme specialization. That if your treatment practice sees individuals with anorexia or bulimia, that usually this requires some additional training about the special needs of this clientele. But in an inpatient hospitalization, they sometimes get admitted to medical floors, sometimes they get admitted to psychiatric floors, but because individuals who have anorexia sometimes require additional medical intervention, which would include a feeding tube. The question is, when would you consider ordering a feeding tube for a hospitalized patient with anorexia? Keeping in mind that individuals with anorexia have a cognition about themselves that when they look at themselves, they don't see themselves as seriously malnourished. They see themselves often as ugly and overweight. So that individual is not necessarily going to cooperate with your attempts to have them gain weight. So the options on this particular one are when the patient's BMI is below 18, when the patient has been physically unable to eat, when it is unethical to order a feeding tube, particularly if the patient doesn't want it, and when the patient's BMI is below 18, which is repeated twice. So you get two options to pick that one. So with anorexia, what they find is that for body weights of less than a certain percentage, that negative things happen to the body, including cellular destruction of as much fat stores as you have, with then turning to destruction of muscle tissue. So how do you think that you might consider this question when faced with an anorexic patient on your unit who has refused to eat and their body weight continues to drop? There's no right or wrong answer on this one because it's not in the readings in Kaplan and Sadek, but it's something to think about. When would you? And it's okay to pick which one you think is best, and then we'll talk about it a little bit. So 5 seconds.
Okay.
All right. I think everybody's gotten a chance to do the poll. So we've kind of got a combination of things here, but what we don't have is we didn't have anybody who thought it was unethical to order a feeding tube, which was really the one answer in there that was clearly something that we wanted to discuss, because there will be times when patients have to have medical procedures ordered for them that they may not care for, but it is a procedure that will save their life. With the treatment of anorexia at this point, it is considered that individuals below 18% BMI should be considered for feeding tubes, just because of the fact that you can't necessarily get them to take enough food orally in a slow process as you could control with a feeding tube in terms of their intake and amount of calories to get their weight up. So anorexia is a disease process that has a high mortality rate. The mortality rate is from a combination of both the anorexia, from the destructive nature of anorexia, in the sense is that when the body is not being fed enough calories, that bone starts to go, muscle tissue starts to go, cardiac muscle becomes deteriorated, and many times individuals may die from the destruction if their anorexia is not treated effectively. The other pieces that can come up with this is that individuals with anorexia often have many other comorbid issues, including serious anxiety disorders, depression, and quite frequently substance use disorders, which alcohol seems to be quite frequently the drug of choice. So even though the individual may not be eating, they may be drinking alcohol, which adds to the complication of the issue. Poor body image, poor self-esteem, suicidality, and death by suicide are other ways in which individuals with anorexia may choose to end their life. So an individual with anorexia is a very complicated individual, which is why we chose not to spend an entire unit on it. The other flip side of the coin is individuals with bulimia and or obesity, which is also considered eating disorders. So as you read through those particular chapters, we just wanted to get you to think about the fact that sometimes you may be faced with making treatment decisions that you may or may not agree with, that you may or may not be comfortable with, but it's important to keep in mind that the patient's safety and well-being is part of the process. So it's not unusual to see individuals with severe anorexia with feeding tubes. Next slide, please, if there is one. Is there another one here, Simone?
Yeah. And again, just a follow-up point, kind of this we're going to be inserting components to questions and answer choices that require kind of remembering labs and normal values and abnormal ranges and those things along the way. So I did not intend to put 18 on on both of those. That wasn't on purpose. One of them was supposed to be 21. But so
Okay, but
we just want to have options.
Either way it works out.
But anyway, my only point is that a BMI of 18 is not low. That it's underweight. Yes, it is technically underweight, but there's a pretty good gap between someone who would meet criteria for anorexia and B, because normal's 19 to 23, 4, somewhere around there. So to kind of just, as we're working with patients, we're going to talk a ton about metabolic issues and obesity, like Dr. Fogger just mentioned, in the next unit. But to kind of remind yourselves, normal BMI, normal labs, normal blood pressures, normal this and that and the other thing. So this is a question related to one of the other readings. Well, two questions related to one of the other readings in the module.
Okay. So the purpose of nonviolent physical crisis intervention, which for some folks who work inpatient, this would be CPI training. So the purpose of this nonviolent physical crisis intervention is to, 1, control a tense situation, 2, for the safety of the patient and the staff, 3 is to keep staff members in control of the patient's behavior, and 4, to limit physical acting out by the patient. So to your clickers and choose the best answer on this particular one. And there is only one right answer on this one. So 5 seconds. And the answer is, oh, excellent.
Ta-da!
Excellent. So safety with both the patient and the staff, because the purpose of the nonviolent crisis intervention is to essentially maintain a degree of decorum, to essentially respect that individual and their space using a treatment modality in which you're taking into consideration that you don't want to re-traumatize this individual, and to work within what you have available to try to quell the situation as much as possible. Sometimes when people are agitated, you'd be surprised about how sometimes food and fluid will help ease some of the distress. So next slide, please, or next poll, if there's another one.
One more.
One more. Well, that's great. We're coming up on 5 minutes to the hour, so
Absolutely.
we're clicking along.
So this is one about kind of test your knowledge, and this is the kind of stuff that ANCC really will want to ask you about.
Okay. Okay, so essentially the Centers for Medicaid and Medicare, CMS, are essentially going to be your oversight, your paying source, your kind of big brother up in the sky, who are collecting big data on things that happen within hospitals. So under what circumstance does Centers for Medicare and Medicaid Services, CMS, need to be notified? So we're talking about restraint and seclusion. And so the options here, and there's more than one correct option. I don't know whether this is set up to allow you to pick more than one. So in this particular case, there's more than one, so you can't go wrong. A patient died in restraints, they need to be notified. A patient died within 24 hours of coming out of restraints, they need to be notified. A patient died within 1 week of coming out of restraints. Or the final answer is nurse practitioners don't need to notify CMS because it's outside of their scope of practice. So please, to your clickers. You've got 10 seconds. All right, Simone, how'd people do?
people did great.
Okay, because there were, you
All of
usually
those
pick,
were correct, except for the bottom one.
yes. So the services need to know if a person dies, in essence, anytime that restraints and seclusion are involved, restraints in particular, because the laws are very specific about that. Joint Commission has standards in which they expect that organizations will be held to. So it's helpful to know that if a patient goes into restraints, that the nurse or the physician must be notified within a specific period of time. They must be reassessed within that specific period of time, that the order is only good for 24 hours, but the individual must remain under constant supervision, observation. Constant means basically eyes on at all times while they're in restraints. And in general, restraints is considered to be a high crisis situation. It's intensive care kind of a thing, that the potential for the individual running into problems while in restraints is pretty high. There are a number of cases that make it to court that are usually around patient deaths involving restraints. So this is a pretty serious thing when a person ends up in restraints. It can be helpful to the individual, but it also is particularly a high risk area. So 3 of the answers are correct. Patient dying in restraints, within 24 hours of coming out of restraints, and then within 1 week of coming out of restraints. And usually within those last 2, that there need to be relationship between the cause of death and the restraint in order for them to make the case on that. So there has to be a relationship there. But so
yeah, there's that article that we have in, I think it's from 2009, but it's from the Joint Commission when they, another national agency who establishes standards for safe practice in really all medical facilities. And there's kind of a middle column. It's a chart, pretty easy to read. You don't need to go, too in depth on that right column, but in the middle it sets the standards of just sort of things that you may get tested on down the road by us or externally, about who can initiate a restraint order and how soon do you have to actually lay eyes on somebody after it's initiated. Say there's not a licensed independent person there, so a nurse will get a verbal. How long do you have for someone, a licensed independent person, to actually show up and say and write the order, sign off on it in person? How often do you have to recheck? So you don't need to know every single thing, but those are sort of key. Who can initiate it? How soon does the person have to be physically in person seen? How long does the order last? Because the ANCC is including questions about some of these inpatient issues. So that's why we're going to be kind of mentioning things like this and mentioning who can admit and what's the discharge process once we get into some later modules, because NPs are working in hospitals. So but always remember your Nursing Practice Act, your scope of practice in your state is going to say you're authorized to do whatever you have training in, be it from an educational program, be it from experience, be it from clinical experiences. So never practice outside of your scope. But our scope is expanding all the time. So anyway, that was just kind of that. Any questions about this or unrelated thing?
I would just say that there is one more slide presentation that Chance Nicholson put together last year that covers more about medication options and doses that are optional and available to you if you're doing inpatient, and keeping in mind that dose escalation in an inpatient unit is going to be much more rapid than on an outpatient unit. So that's one of the primary reasons people end up getting admitted to is to quicken the possibility of getting medications on board and getting them feeling better.
And we don't have speaking of that other PowerPoint, we don't have class next week with it being the day after Memorial Day, but what we can do is open up a discussion board specific to this module to kind of address some key points to that and allow y'all to ask questions and maybe work through some scenarios to try to bring that into the fold, that additional material on this topic. But that's all I had.
And there's an exam coming up, and
Oh, yeah.
related to that, this unit and the first unit would be on that. With the first unit, in terms of treatment options, Wheeler really writes quite well, and so many of the chapters in Wheeler will help you to understand some of the underlying pieces, if for no other reason than the fact that it's something to be aware of, particularly with the various other therapies that you could do, including group therapy, to know kind of Yalom's 11 benefits of group. A lot of times theories will come up and different treatment modalities on this particular exam. So even if you don't have an opportunity to sit in a group therapy session, to at least know the underlying principles and be able to pick out a response that is a reasonable answer if you see a question on that.
Yeah, we posted, speaking of that, I'm glad you brought that up. It reminded me, there's two YouTube links posted in 623. One is 12 minutes long and gives a really good example of how you might use some cognitive behavioral techniques with a patient for a variety of reasons: anxious about something, not taking a medicine, arguing with a relative or coworker, feeling depressed, whatever. Just a really good brief example. The other one's very long, but it's, if you want to just kind of scroll through and catch a couple minutes here and there, it's three different examples of three different therapy approaches, conceptual approaches to therapy by three people who invented three of the most famous therapy modalities ever. So just kind of for an example of those. Don't watch the whole thing. I think it's an hour and 20 minutes, but to just get a flavor of little bits. And that was recommended by one of your classmates, so I cannot take credit for that idea. But that's it.
Are there questions from tonight before we call this session to an end and wish you all happy Memorial Day?
Mm-hmm.
Questions, anyone?
Oh, one more thing. We're gonna be bolusing the education validation letters to the ANCC in the next week or so, at which point you should be able to schedule your exam. And please look at, you can find it online too, but there's a $125 off discount code for that for folks who are currently in a program. So if y'all need a letter from us, just email either me or Dr. Fogger. But the code is good through June, so it's not like it's going to expire. They'll have your information by then. So.
And if usually, because they keep putting those out, and if the person doesn't decide to register by June, they probably will send another one out for July.
Yeah, probably.
I've been watching them roll them through for the months, and this is your last opportunity. I've been sending out requests to the American Psychiatric Nurses Association for membership, and hopefully the folks from the last batch have been contacted by Ms. Fedorenko, and a couple more people since I sent that out have contacted me, and I have yet to send those out. So if you're interested and you haven't done it yet, this is kind of like an opportunity last minute to say you're interested in joining APNA for $25. Look to see how much money it'll save you, and then if I haven't been contacted yet by her, should I worry? Shalita, I sent that message out last week, and I didn't hear back from her myself, so she may be on vacation. But if she doesn't respond, say, by Thursday, just email me back and I'll resend out the email again. because there were a number of people who were also on it, and we want to make sure that everybody gets signed up, and I can add the other folks who contacted me after I sent that letter. So it is worthwhile to join an organization right now while you're still a full-time student and you're full-time for the American Psychiatric Nurses Association purposes. So there you go. Anything else, Simone?
I think that does it. So we'll stop the
Rob?
recording.
Yeah, Rob just said that he didn't hear from them either. So everyone who had asked me since our last on-site, I could include it in one letter with everybody CC'd in on that particular one. So if one person hasn't heard, the other people haven't heard. So we'll just resend it again if by Thursday you don't hear anything. So that's how we'll do that.
All right. Lock and load.